This video is about an endoscopic en-bloc resection of a upper urinary tract tumor. This case is about a 79-year-old male, ASA2 with a Charlson Comorbidity Index of 6. He presented initially with haematuria and underwent a flexible cystoscopy as well as a CT scan. Flexible cystoscopy did not show any abnormalities, however CT scan demonstrated a small filling defect in the left renal pelvis. Showing now is a ureterorenoscopy performed following that CT scan. The procedure begins with systematic mapping of the renal calyces to ensure optimal visualization of the tumor's location and extent. This step is crucial for the planning of the resection of the tumor. Once the tumor is identified, a circumferential incision is made around the base to separate it from the surrounding urothelium. This controlled incision establishes a clear margin and facilitates en-bloc resection. Navigation through the calyceal system is achieved using a combination of scope rotation and controlled advancement with the left hand, allowing for precise positioning and optimal maneuverability. As the dissection progresses, the natural tumor plane is carefully developed by identifying and following the fine fibrous attachments, also known as cobwebs, underneath the tumor. The weight of the tumor itself is utilized to encourage medial displacement, permitting extension of the incision beyond its base for a more complete resection. Blunt dissection is then performed along the tumor's contour, using gentle pressure from the endoscope and controlled irrigation flow to further separate it from the adjacent tissue. By systematically mobilizing the tumor in this manner, it is ultimately left suspended on a narrow pedicle, allowing for its final detachment with minimal trauma. This technique enables precise en-bloc tumor removal while preserving surrounding structures, offering potential alternative to conventional methods such as nephroureterectomy in select patients. The following are histology slides from the biopsy specimen. At low power magnification, we observe the nested architecture typical of low-grade transitional cell carcinoma. Moving to high power magnification, the tumor shows obvious papillae and fibromuscular cores extending into papillary projections, a hallmark feature of papillary urothelial carcinoma. Additionally, the specimen on the right suggests that there are no muscle involvement. A follow-up ureteroscopy at 6 weeks showed no evidence of recurrence and biopsies were negative for malignancy. As you can see in this clip, the patient is clear of urothelial malignancy. Thank you for watching.